Hi, my name's James Burleson, and today I'm going to be talking about characterizing osteoarthritis severity from autosegmentation of CT images in the ME approach study. So a bit of background about me. I originally studied theoretical physics here at Manchester and then joined iMorphix in 2015 after graduating, where I now work as a computer vision engineer. iMorphix was originally a research spin-out company from the University of Manchester's ISB group, which was under Professors Tim Coots and Chris Taylor. Shortly after I joined, it was then acquired by the Stryker Corporation, which is a global medical device and healthcare company. I work in the clinical trials group, which is a continuation of one of the original iMorphix groups, which applies machine vision and learning techniques for clinical applications and pharmaceutical drug trials. Quick bit of preamble. Knee osteoarthritis is a debilitating disease which is often considered for surgery as it affects a lot of people, and in the advanced stages of the disease, surgery is often the only thing that provides adequate relief to the patient or improvement of function. However, one of the key challenges in that is assessing the structural pathology of the patient and determining how advanced their disease is. Traditionally, this is done with several methods, but one of the main ones is using the Kellgren-Lawrence scale, which relies on taking a plain film radiograph of the patient and having an expert reader look at that image and assess it on a 0 to 4 scale based on how osteoarthritic they believe it is. However, that scale has different features which are looked out for at different levels, so it's not a linear scale, and it also suffers from all of the issues with inter and intra-reader variability that you would get with any other semi-quantitative score. Quick bit of illustration about some of the issues with assessing OA from a plain film radiograph. Now, on the right, you've got a X-ray of a patient's knee, and on the left, you've got a 3D segmentation of the same knee derived from an MR image. Now, as you can see quite quickly, as indicated by the red arrows, there are some osteophytes which they're visible in 3D, but they're completely obscured by the rest of the bone in your radiograph. You will also see sort of false osteophytes, which look like outcroppings on the edge of the knee, but which in 3D we can see are actually shape changes in the posterior of the knee, looking like false osteophytes. You can also similarly get false joint space narrowing on the right-hand side of the image, where in reality it's just because of the view angle that the X-ray was taken at. You also get what is often referred to in the literature as subchondral thickening of the tibial plateau, when in reality what it actually is when we assess this in 3D is the plane flattens, and this means that you get a kind of longer path that the X-rays have to take when they go through the tibial plane, which makes it look like it's got a higher radio density, i.e. it's thickening, when in reality it's just flattening. One of iMorphic's core technologies is producing 3D segmentation of anatomy from images using, for example, 3D active appearance models, one of which we can see here on the left, segmenting a femur in MR. Active appearance models are statistical shape and appearance models which can fully and automatically search an image, in this case in 3D, and produce a set of corresponding landmarks on the surface of the segmented anatomy in question. These corresponding landmarks allow us to analyse shape changes across a large population or for the same patient across multiple time points, or a combination of the two. We did this for the OAI, which is the Osteoarthritis Initiative Study set of images, which is over 40,000 MR images across a broad patient population. From these shapes, we can look at the broad shape changes between populations identified as OA and non-OA according to KL grade. And if we animate the model here on the right, from non-OA to OA, we can see through the population overall, you see the growth of these kind of classic ridge of osteophytes, the so-called pie crust of osteophytes around the outside of the femur, and also the general broadening and flattening of the articulating surfaces, as well as joint space narrowing. So to clarify a bit, here we have a schematic diagram on the left of the OAI dataset, the segmentations of it, and their separation into two subpopulations of patients defined as OA and non-OA according to KL score. Of those two populations, you can then compute a mean in shape space, and then between those two means of the two populations, you can calculate a direction vector between the two in your higher dimensional shape space. And in our case, we then normalize the distance along that vector by the standard deviation of the healthy population. And then for any given segmentation, you can effectively project it onto that line and then calculate the normalized distance from your chosen origin, which in this case is the mean of the healthy population. And from that, we define what we call the B-score, which then, as you can see on the right, if you animate the mean shape model along that direction with an increasing B-score, you can see the growth of the classic osteophyte pie crust and the broadening, flattening of the articulating surfaces. So we use this as a sort of automated measure of structural pathology in knee osteoarthritis of the femur. With this B-score framework in place, you can then take any MR image of the same modality of any patient you like and generate this same automatically derived objective measure of the osteoarthritis state of that knee. And this is particularly useful for a endpoint in measuring the effect of drugs that modify osteoarthritis. And as such, it's been used in several clinical trials at this point. I've listed two of them there if you want to go and read the published results. Additionally to that, it's also got potential for use in surgical assessment and planning, as I've alluded to earlier. But the issue with that is that pre-surgical images are usually CT and not MR. So we come up against the problem of how do we derive this same shape score from a different image modality. So here's how we go about getting the same B-score but for a CT image. So we start off with the CT image and then segment it with an auto-segmentation model that, instead of being trained on MR, was trained on CT, so it can segment in that modality. Once we have the 3D surface, which you can see displayed there on the right, we can then convert that to a binary volumetric image, just a sagittal slice through there to give you an example. And then that image can be segmented by a binarized version of the MR B-score model. And then with a few small surface projection and smoothing things to make sure that it lies as close to the or on top of the CT segmentation as possible, because there's a few small discrepancies, but they're all relatively small. That allows us to essentially place the MR correspondence points on top of the CT surface. And then once you have that, you can compute a equivalent B-score for CT as normal. I say equivalent, which of course begs the question of how equivalent. Now, in order to answer this, we took images from the IMI approach study, which was a 2-year prospective study consisting of 424 participants, in which they took pairs of CT and MR images of the same patient at the same time point across a large patient population, which allows us to calculate the CT and MR B scores for each patient pair of images and see how well they agree over this large population. In doing this, you get the following linear regression and Bland-Altman analyses plots, which show that there's a nice strong linear correlation, which is actually quite close to unity, which is shown by that dashed line on the top right corner of the left-hand plot there. And R squared and other similar correlation metrics are pretty high, R squared being 0.96 in this case. And from the Bland-Altman analysis, you can see there's almost no bias between the two, which means there doesn't appear to be a systematic offset as far as we can see. And there's also no value dependence in any sort of offset. It's quite a flat Bland-Altman plot, which suggests that there's no kind of B-score dependence in the agreement between the two. Even up to more advanced disease, you still get good agreement. The 95% confidence limits also show that the spread is quite small. It's within a single B-score unit there. As part of the IMI approach study, the participants were also given a KL grade, which allows us to stratify things like our CTB score by KL grade to see how the two compare. Now, if we do this, we can get this nice set of box and whisker plots showing the distributions of CTB scores for each KL grade cohort. And we see a sort of overall curvilinear relationship with this sort of upward tick towards KL2+. But also, interestingly, there is a sort of separation into two groups here, where KLs 0 and 1 are sort of broadly similar, whereas KL2 plus shows this kind of upward movement, which when we look at the definition of OA and non-OA in the KL grading system, they define anything with KL grades 0 or 1 as non-osteoarthritic, and anything as KL2 plus radiographic osteoarthritis, which kind of lends credence to the idea that we are measuring something which has some analogous properties to what is being determined by KL grade, just with more resolution and sensitivity and consistency. So what does this all mean? Well, the main takeaway is that CT B-score shows good agreement with the original MR method of calculating B-score, which gives us confidence that we can measure B-score with this method when we don't have MR images and we have CT instead. This is encouraging for the viability of using this in preoperative assessment for knee arthroplasty, because, as I've said previously, in that case you usually have a CT image and not an MR. And it also lends credence to the idea of doing B-score analysis in osteoarthritis trials where the imaging is CT rather than MR. Thanks for listening.